Coming up next on primary care, pain management. Research shows black patients are often undertreated.
One type of pain is not the same for every person that comes through the door, right? So back pain is not back pain for that person as this person, just like diabetes is not diabetes for everybody.
Hello and welcome to Primary Care, the show dedicated to improving the health of African Americans. I'm your host, Dr. Lonnie Joe. Studies show that African Americans often don't get the same pain treatment as others. They're less likely to be prescribed pain medication or may get lower doses, even when they report the same level of pain. In fact, research finds that black patients are 40% less likely to receive pain medication compared to white patients. This gap in care, driven by a systemic bias, is especially clear in managing chronic pain. Joining us today to give us a greater insight in this is Dr. Stephen Wilson. Dr. Wilson is a leading expert in pain management with nearly 25 years of expertise and is board certified in both physical medicine and rehabilitation and pain medicine. He specializes in combining traditional and alternative treatments to help patients manage pain. Stephen, welcome to the show.
It's a pleasure.
Good. Thank you for joining us. Research published in the 2007 Journal of the National Medical Association found that physicians are twice as likely to underestimate pain in black patients compared with all other ethnicities. Dr. Wilson, why do you think this bias in pain management continues to exist?
Well, there's various reasons why there's a bias that's there. Sometimes there's a perceived response to pain. Let's say someone says they come into the office and they say, I have a pain that's, what's your pain scale? Is it a 1 or is it a 10 out of 10? And some people will come in and say, I have a 20 out of 10 pain. They'll come in and they'll embellish their pain. And it may not be an embellishment, but it may be perceived as if they're embellishing their pain. And then there's just the automatic stigma of someone being perceived a drug seeking type of patient. And so those are the sort of things that kind of lead to the bias that people see based upon their racial ethnicity.
So people will actually interject into an office visit or a interaction with a patient that, well, because you might be of a certain ethnicity, you perceive pain or have pain needs or perceive pain differently, or basically after you've ruled out the drug seeking aspect, which we'll talk about also, that you can bear more pain than the average person out here. You don't need as much medication.
Yes, yes. Those are all like biases that are kind of built in to the perception of what a person has in terms of pain. So let's say a patient goes into emergency room and they have a painful episode because their pain's not being perceived as being as real pain. And so they don't want to give them medication, so they're undertreated in that situation when they have pain because they're seen as being drug seeking, right? Then they'll come back to my office and they'll see me, and if they're, I'm like, why did they treat you for your pain in the emergency room? Well, they thought that I was drug seeking because I had this episode of pain. So, just based upon that particular bias, I think that's what kind of deters, the pain management.
I think in primary care, all of us have had to deal with patients who have been in the emergency room setting and probably had to answer 50 questions by 3 or 4 different people before people say, okay, give them something for the pain. That is a reoccurring theme as we see it right now, especially with the narcotic situation or the illegal narcotic situation that we have to deal with.
Exactly.
We have all of these social and societal issues that influence pain in treatment, especially in the control situation where we really want to help people.
Right.
We really want to get them out of their pain, but you got to dig through the maze in order to get there to say, okay, now I know what we're dealing with. This is how we can help folks.
Exactly. That's exactly the right point there. Yes.
But here again, it's got to be a nightmare for you at times to be able to do that.
Oh yeah, yeah. It's a nightmare. It's a challenge. That's the thing. I like challenges, and every time I see a patient, it's a challenge. And one type of pain is not the same for every person that comes through the door, right? So back pain is not back pain for that person as this person, just like diabetes is not diabetes for everybody, right? And so I treat that one person special, just like their pain is their special pain, and we find out exactly the cause of the pain. And then from there, you can actually get a diagnosis and get the proper treatment for the pain.
So talk about the variety of the types of pain that you see in your practice.
Well, what I see, because I'm physical medicine and rehabilitation certified, I treat pain from a rehabilitative standpoint. So physical medicine and rehab, physical medicine and rehab. So we're rehabbing people, and so we see people who had strokes, spinal cord injuries, arthritis, all different types of conditions. So when we're talking about pain, I deal with all types of pain. Give me migraines, neck pain, low back pain, knee pain, ankle pains, ankle sprains, ACL tears, back pain, rotator cuff, herniated disc, sciatica. So the gamut is like widespread. But if we're looking at the major diagnoses that I see on a regular basis, is low back pain by far. And then number 2 would be cervical pain.
Okay. So basically, there is a non-medical approach incorporated into the treatment plan of, as opposed to just swallowing some pills.
Oh, 100%. Yeah, yeah. So when you're dealing with pain, you have to look at it from a multi-disciplinary, multifactorial sort of approach. And that's what I've kind of geared together in terms of treating pain from, okay, so there's the psychological aspect of pain. There's the actual inability to sleep that affects their pain. There's the actual nociceptive component. There's this chronic unwinding of nerve endings that happens with pain, chronic pain. Okay, and then there's there's that cancer pain that's just there persistent. So you have all these different like aspects of pain that's affecting it, and so you want to find out exactly what it is and treat every aspect of the pain, so you bring it down to the point where it's controllable, and the key is their function improves.
Exactly.
Because pain is perceived. So someone can say they have pain, but how does it affect your function?
Right.
And that's the magic word, is their function.
Right. So helping the patient understand the approach to the treatment of the pain is just as important as any medication you can give them.
100%. Yeah. That's what you have to do. So I find in this world, we don't have, as practitioners, we have a limited amount of time. Time and money are kind of like synonymous sort of situations. So they limit our time, so then you have to make the best use of your time when you're seeing someone. I spend a little, I'm in private practice, so I spend a little extra time to make sure I explain it to them. So I bring out my Frank Netter anatomy book, and I'll pull out the book and I'll explain to patients from A to Z exactly how the nerves traverse, how they affect the muscles and everything else, and then we gear a treatment based on that. But that's after I've figured out what the diagnosis is.
Non-pharmacological treatment. In most instances, we'd like to start there in the approach of any pain. Is that as successful, especially under the current setting with all of the illegal drugs that are available for patients to make themselves available? Is non-pharmacological treatment providing any kind of patient relief that we can say, boy, this is something that we cannot leave out of the equation?
That's another excellent question, because when you're looking at pain or any treatment, you always start with the most conservative approach, and then you go from the most conservative to the more invasive or the more risk involved.
Exactly.
Right? So when we're looking at conservative stuff, the actual non-pharmacologic situations don't involve the actual side effects that you run into with the medications and other treatments. So it's always incorporated, and you always treat the actual non-pharmacologic treatments first, and you add those in, and that becomes a part of the multimodal approach to treating the pain. And,
So-
they do work, though. They work to
yeah.
actually help control the pain.
I mean, Steve, I've had lots of patients talk about meditation and yoga and all of those various types of non-pharmacological things that you would think that has nothing to do with pain. Basically do things like bring the pain level down to help them be functional.
Yes, that is exactly right. And so what we got to change the paradigm shift from treating pain to actually improving function. Right? And so if we're looking at, okay, yoga, meditation, this sort of thing, if it's improving their function, and yeah, they're still going to have some pain, but their functions improve, success.
So a program has to be designed
Yes.
for each individual patient
Each individual.
that walks through the door
Yes.
to start talking about, we know where we want to go with this.
Yes.
The idea in mind is pain relief.
Yes.
But along the way, we want you functional as we progress toward that pain relief.
Yes. Yes. That's exactly right. That's the beauty of it. And that's the art, because each person, individualized treatment for that person to improve their function.
How about that? Dr. Wilson, off camera you were just mentioning how a lot of these patients have been everywhere. They've seen the orthopedic surgeon, they've seen other pain specialists, they've seen an internist, they've seen a family medicine doctor, they've even seen their pastor about all of this stuff surrounding their pain and can't get out of it. How can we help patients buy into the treatment approach for pain, helping them understand that there is a better way to deal with this?
Well, after I see patients that have this sort of, that's been around from doctor to doctor, I look at the pain and I ask them specific questions and try to get my own diagnosis as to what's going on with their problem. And then once I figure out a source of the pain, then we can actually gear the treatment towards it. Getting a patient to buy in to the treatment is to actually spend time and actually do a thorough evaluation, physical examination, explain to them how they can become empowered in their actual diagnosis. So you have something going on with your body, you have a disc herniated, you want to know why you have a disc that's herniated in your body and what's going on, why you have these symptoms. And one of the fears that we have in our community is that we're afraid of doctors. We're afraid that they're going to tell us something bad.
Right.
Right?
Bad news.
Bad news, right? And so the thing is, you know, I don't want to tell you, I'm going to tell you news, but I'm going to tell you like what's going on and what we can do to fix the problem, right? So now one aside here is that when a person comes in and they have a herniated disc, they automatically think that, hey, I'm going to need to have surgery on my back. And if they go to the right person, they'll do it. We get problems that incur after these things, after you have surgical intervention. So my job is to prevent the surgery from occurring as long as possible. But when the rubber meets the road, then hey, you have to have it. You get at that time. But beforehand, I wouldn't recommend that.
So with primary care in most instances being the first line of encounter these kind of issues, when should the primary care provider be referring to someone like yourself?
I'd see myself as the primary care of pain management. Okay. So primary care, once it gets to the point where, okay, primary care doctors can't spend as much time as I could spend with the patients. But if you send your patient over to, let's say, a pain specialist, that's someone in PM&R, pain management, they actually are going to look at it from a multimodal approach, and then surgical if need be. But they're going to try every way possible to keep them from having the surgical intervention, so that then you have the best outcomes for your patients.
So you touched a little bit earlier on the fear that patients have about doctors in general. Is there a heightened fear that in this pain management arena that patients have, especially in terms of, I may need to have surgery?
Oh yeah, no, I mean a lot of people don't want to have surgery, and they want to try other modalities, other things to actually control their pain. Some people rather have surgery as opposed to being on opioid medications, right, long term. So there's stigmas and fears both ways. So I get it all different directions. I get it where the person says, oh, no, I don't want any opioid medications. I don't want this. Well, I'm not trying to get you, because once you start, then it can lead down a slippery slope.
Correct.
Right? So that's why I try as many of the conservative things first before we get to that level.
So speaking of the patient who has been on opioids long term, I think these are some of the saddest cases that we see, because sometimes it goes back years. And you're saying, boy, you mean to tell me you've been taking this quantity and type of medication for this length of time? Does that represent a special challenge, and what modalities tend to break that cycle?
After a person's been on pain medications for a while, they develop what's called a tolerance to the medications.
Almost like it doesn't work.
Like it doesn't work. So they're taking it like chiclets, right? And so the pain medication doesn't give the same response that they would have had before. So typical, what you would do is you would actually slowly wean a person down to give them what's called a drug holiday, where their body actually is, their opiate receptors are reduced because they're actually upregulated and they're increased. And so you reduce their opiate receptors, so then now a lower response will give the response that they were getting at higher levels. And that's where the problem becomes. And then, when they're taking these high levels, and I want to make sure I say this, is that another medication can be added to this high level of medication, such as a benzodiazepine, alcohol, let's say anything that interferes with this drug's metabolism can cause a person to die or have respiratory problems. So that's the opioid crisis that we're seeing, is because they're on these high levels of medications, another drug gets introduced, and then they have the respiratory effects of that, or cardiovascular.
In an urban setting, though, we just see to a great degree the problem with the use of illicit drugs higher amongst the black patients than other ethnic groups. Is there a issue with availability of services, getting over the trust barrier by being able to see a black pain specialist such as yourself in this area? I mean, we can count on one hand the number of people we have in metropolitan Detroit with such a huge problem. We can count on one hand with the people here who are African American who do what you do. How do we combat that? I know training is always an issue and getting people in the pipelines to do that, but it seems to me that we should be able to do something else to improve this outcome, which is right now not the best.
I would say referral to pain specialists. My practice is a mixed practice. I see pretty much everybody that comes in. However, I see more people referred to me from Caucasian physicians as opposed to African American physicians. Less African American patients that come in comparatively, right, to come see me. And I know there's a huge need that's out there, but there's people who are totally being not treated properly, and that's where we're failing in the system. Yeah.
How do we explain the distribution of these drugs? Sometimes we see variations in what's distributed in pharmacies in minority communities as opposed to suburban communities when it comes to opioids.
That's another, a bias that's present. And so the availability of different medications in different communities is less so in African American communities, maybe because of the biases that's there and stigmas. But it could also be because the referring physicians are not putting in the proper medications and prescriptions that's given to patients.
Okay, that's very interesting, because some patients come out of this whole game as drug seekers. They've got that label, they're frequent flyers to the emergency room, and the outcome seems to be the same. They don't get the seriousness of attention. They may or may not get medication appropriately. They certainly don't get the proper referral to definitely begin to deal with this, over the long term. So we've just got a lot of work to do in this area.
Yes. There's, I think, iatrogenic causes of these problems that we're having, right? And that means that physician caused problems. And so the physician is actually maybe creating a problem by under treating pain. So now the patient says, hey, I'm going to get some sort of treatment of this, and then they turn to the illicit medications that we're talking about. Or maybe medications that are toxic to their kidneys, their heart, and things like that in terms of NSAIDs, that sort of thing. So there's a whole host of problems that arise.
Right, so there is a added responsibility, at least on the providers, to actually take more of an interest and a concern in this whole problem and this whole prescribing issues that we have now going forward. The state of Michigan now requires people to have CME training in terms of addiction to some degree. And a lot of states have done that. I think 38 states out of all of them now are doing that. Do you really see that has been beneficial? We've been doing it for a few years now here in Michigan. Do you think that has changed physician attitudes at all?
It's lowered the amount of medications that patients have been on when I see them in a referral setting. Before, I would see people on high doses that would be referred or asked for a referral, and I never get to high levels of medications. And so you get into the problems when your opioid MEEs are too high.
So what can we expect? I mean, like some patients for various other things have implantable devices for pain. Do we have anything that would be similar in the use of opioid addiction?
Well, there's a new medication that they're supposedly coming out with.
Yeah, we're looking for
Journevax, right? And this one is a medication that's supposed to work on the peripheral nerves, but it's only indications for acute pain. And so that's something that's coming down the pipeline. It's been FDA approved, and it's actually, I haven't seen it in the pharmacies yet.
Yeah, it's not available yet, quite yet.
A lot of the medications that are available like that, the cost is high and insurances don't cover, so there's your barrier to actually implementing the actual treatment. There's no one cure-all for anything. So implantable devices, they do, sometimes they work, sometimes they don't work. Like TENS unit, electrical stimulating devices, the leads become dislodged from the actual spinal cord in those situations. TENS units, some people work, other people's don't. So it's a variety of different mechanisms that you use. That's why it has to be multimodality.
Dr. Wilson, we can't let you get out of here without talking about cannabis and the role that it plays in pain management, because it's everywhere now, legal in a lot of states, even though the feds still have a problem with it. We're going to have to deal with that as an issue. What's your approach?
Patients that I have that's on cannabis, I've noticed that the requirements of opioids that they're taking is less. So when a patient comes to my office, even prior to it being recreational usage, they would have the cards that you fill out, and I would sign off on the cards and allow them to do that, as long as we had a dialogue between the two of us. The problems that I've seen is that patients that get marijuana from other means outside of the legal structure, they'll have like cocaine that appears in their urine. And so then there's a question of, are they using cocaine in addition to the marijuana? And my patients that I trust swear by the fact that they're just taking the marijuana and they don't know how the cocaine got into their system. And it's been consistent that this has happened. So so as far as marijuana comes into play, I think it's useful. I don't recommend people smoke it because of the lung issues in terms of inhalation. Orally, the actual absorption is not as strong as taking it through inhalation, but you don't have those issues in terms of the lung issues and that sort of thing.
So you're not opposed to it as a pain specialist? You're not opposed to it?
Not opposed to it.
So you mentioned acupuncture earlier.
Yes.
Tell us how that compares with other modalities of treatment in your practice.
So I use In terms of complementary treatments, I use acupuncture. I use this treatment called IMS, intramuscular stimulation. I do PRP, platelet-rich plasma, prolotherapy.
You do platelet-rich plasma?
Exactly.
In the office?
In the office.
Okay.
I do, and all my injections that I perform in the office are done under ultrasound guidance.
Okay.
So I actually put whatever my medication is or whatever is being located right at the site of where the pain is at. So you figure out the pain generator, put it right where the site, most effective in our treatment. Acupuncture is just needles. Right? Needles and electricity. So I put the needle along these electrical points, okay? And in terms of like Eastern thoughts there, they think that, okay, there's these meridians that go through the body, and you're unblocking the blockage that's in these, that's blocked in the person, and that unblockage causes the pain to be reduced. Well, I put the electrical things on there, hook it up, send electricity, and bam, they get better. But it's once a week for 5 weeks. That's how I do the acupuncture.
The entire length of treatment.
The entire length of treatment. And after 5 treatments, if it doesn't work, because nothing works 100% for everybody, after 5 weeks, if they're not getting improvement, then I abort. But if it does work, then we have something. Medicare is paid for it the last couple of years. So that's positive.
That's interesting. So a little bit less of a barrier to getting that type of treatment. Stephen, this has been outstanding, and it's good to know that somebody's in the forefront and looking down the pike what's coming and treatment, because this pain situation is not going to go away.
No.
This is going to be a constant in patient care no matter what we do. So we're looking forward to all of this new stuff that's happening also. Good. We appreciate you coming on the show today.
Thank you so much. Thanks for having me.
Absolutely. Such a pleasure. Our guest has been pain management specialist Dr. Stephen Wilson of Advanced Physical Medicine. No one should have to fight to have their pain believed or treated. It's time for equal care, equal relief from healthcare systems that listen. For primary care, I'm Dr. Lonnie Joe.